Just once again, my name is Roger Sekabena. I'm a pharmacist and researcher here at Baylor, Uganda CRS. I am privileged to be your chair for this module, module 6. And for this module, we're going to be looking at introduction to pharmacokinetics and pharmacodynamic studies. We also have a practical session. The session is going to be presented by Anne Campos and Angela Kolbach. These are our presenters for today. Anne is a pharmacist and a PhD candidate at Radboud University Medical Center, which is based in Netherlands. Angela, she's also a senior researcher at the pharmacy of Radboud University Medical Center, which is also based in Netherlands. And her interests are in pharmacology studies, specifically in pregnant women and children living with HIV. So the session will start with a presentation from Anne, and then Angela will take over from Anne for the rest of the session. At the end of the presentation, we will have a Q&A session for our presenters to respond to your questions. Thereafter, we'll launch an evaluation pool for module 6 after the Q&A session. So please join me in welcoming Anne to make her presentation. Over to you, Anne.
Yeah, thank you, Roger, for that introduction. I will share the presentation now. So after this lecture, we hope you will understand the concepts of pharmacokinetics and pharmacodynamics. You will learn about the absorption, distribution, metabolism, and excretion of medication. You will familiarize with the key pharmacokinetic parameters, understand why we do pharmacokinetic studies, and specifically pediatric pharmacokinetic studies. And we will discuss common pitfalls in pharmacokinetic studies. So there's a lot to tell about all of these topics, but unfortunately, we cannot get into that much detail in just 1 hour. But we will try to give a brief overview of the concepts of these topics. Just to confirm, you guys can see the next slide now?
Yes.
Okay, great.
Yes, Anne.
Okay. So what is pharmacokinetics? Is it what the drug does to the body, or is it what the body does to the drug? Well, pharmacokinetics is what the body does to the drug. If we talk about what the drug does to the body, we talk about pharmacodynamics. We assess pharmacokinetics by measuring drug concentrations in the blood or in other matrices after a medicine is given to a person. And by measuring these blood concentrations, we can make a pharmacokinetic curve, as you can see here on the right. The x-axis shows the time after administration of a drug, and the y-axis shows the concentration. And such a curve shows us the total exposure over a certain period of time, which is often 24 hours. So in this figure, you can see an overview of the processes that can take place after a drug is administered. And it shows the differences between pharmacokinetics and pharmacodynamics. So after a drug is absorbed into the systemic circulation, so into the blood, distribution to tissues will take place and drugs will be metabolized and eliminated. So these processes together, the absorption, the distribution, the metabolism, and the elimination are the pharmacokinetics of a drug. So drugs in the system, in the systemic circulation that is unbound, is free to move to the site of action and can subsequently cause a pharmacological effect. The concentration of a drug at the site of action, as well as the actual pharmacological effects and the clinical response together, are the pharmacodynamics of a drug, as you can see here. So now you know the differences between pharmacokinetics and pharmacodynamics. We will get into more detail on the different processes of pharmacokinetics. So the absorption, the metabolism, the distribution, and the excretion. So absorption of a drug is the process by which a drug proceeds from the site of administration into the bloodstream. All drugs undergo absorption, which mainly takes place in the gastrointestinal tract, except from drugs that are administered intravenously, since these drugs are administered directly into the bloodstream, so into the systemic circulation. There are different ways a drug can be administered, which means that there are different ways a drug can be absorbed also. As mentioned, drugs can be taken oral or intravenously, but there are also drugs that are administered intramuscular, rectally, or through the nose, for example. The different routes of administration will influence the shape of the pharmacokinetic curve, as you can see here on the right. So if a drug is absorbed into the body, for example, after oral administration, some of it can already get lost before entering the bloodstream. So only a fraction of the drugs that is taken will become available for action. We call this the bioavailability of a drug. So it is the fraction of unchanged drug reaching the systemic circulation, so the bloodstream, after the drug is administered. If a drug is given intravenously, no drugs will get lost in the process of absorption, as explained, because everything will be administered directly into the bloodstream. So there's basically no absorption. This means that the bioavailability of a drug that is given intravenously will be 100%. So you can either administer a drug orally, and in that case, some of the drugs will get lost during absorption, or you can take the drugs intravenously, and in that case, the bioavailability is 100% as explained. So now the absolute bioavailability of a drug that is taken orally can be calculated by dividing the exposure of a drug when it is taken orally by the exposure of a drug when it's taken intravenously. And this is also shown in the figure here on the right. If you perform a pharmacokinetic study and you decide on what these sample schedules should look like, you will need to think about the expected speed of absorption of a drug, since it is important to get accurate information on what the first part of a curve looks like. So now we discussed the absorption, we will move on to the next process in pharmacokinetics, which is the distribution of a drug. So after a drug is absorbed and available in the bloodstream, it will distribute to tissues and organs in the body. So the distribution of it is the movement of a drug between the blood and the tissues. There are several factors that affect the distribution of a drug, such as the physiological volumes of patients, the movement across membranes, and by this we mean whether this is an active or a passive process, but also the lipophilicity of a drug, so whether a drug prefers to be in a watery or an oily environment. And lastly, the binding to tissue components and protein in the blood, for example, albumin, because a drug needs to be unbound to be able to move across membranes into the tissue. So as mentioned, one of the factors influencing the distribution is the physiological volumes of patients. There is a lot of variability between people within a population. For example, distribution of a drug will be different in a healthy young adult compared to somebody who is sick, or compared to a child, for example. So now we discussed the absorption and the distribution. We move on to the next pharmacokinetic process, which is the metabolism. Most of the drugs are metabolized by enzymes that are present in the liver. And the reason that drugs are metabolized is to make them more soluble, so they can be excreted and removed from the body. As mentioned, most of the drugs are metabolized by the liver, but metabolism can also take place in other organs. Most of the metabolites are inactive, but some can be active. And this is the case, for example, for certain prodrugs, which is a drug that needs to be metabolized before it is active. And examples of prodrugs are tenofovir alafenamide, or TAF, and tenofovir disoproxil, or TDF. After these drugs are absorbed into the systemic circulation, they will be metabolized to the active component tenofovir, as you can see in this figure below. And tenofovir can then be taken up by the cell to the site of action to do its actual work. So drugs are often metabolized through multiple pathways. So multiple enzymes are involved also. And an example of such a drug is the antiviral drug dolutegravir, which is metabolized by CYP3A4, which is shown here, but also by UGT, for example. There are many different hepatic metabolic enzymes, as you can see in this figure. The enzymes that are most abundant are the CYP3A4 and UGT enzymes, and these are also responsible for the metabolism of most drugs. Then after a drug is metabolized and is made more soluble, the drugs can be renally cleared from the body. So this can be done by either glomerular filtration, what happens for unbound drugs and small molecules, or by clearance that will take place through active transport. And as you can see in this figure, there are different transporters present in the renal tubes that are responsible for the secretion and the reuptakes of drugs and other compounds that are filtered from the body through the kidneys. So if a drug is removed from the body by glomerular filtration, the glomerular filtration is an important factor for estimating the renal clearance of a drug, because a decreased renal function can result in an increased drug exposure, since the drug won't be cleared as well, and it will be present in the body for a longer period of time, and thus the exposure will be greater. The renal function is often estimated by measuring the creatinine clearance. And some may know this already, but creatinine is a muscle breakdown product that is excreted renally. So measuring the clearance of creatinine from the body gives an indication of the renal function. So we talked about the different processes and aspects of pharmacokinetics now. And in this figure, you can see a clear overview. After absorption of a drug, it will be distributed throughout the body. And then free drugs will do its work at the site of action. After this, drugs will be metabolized, and eventually it will be removed from the body through either the feces or through the urine. If we want to get more insight into these processes of what the body does to a drug, we can take a pharmacokinetic curve. We do this by taking multiple blood samples from a person after administration of a drug. And after measuring these samples, we construct a pharmacokinetic curve like this, which shows us the drug exposure throughout the whole day, like that. And from this curve, we can see what the absorption looked like, but also the distribution, the metabolism, and the elimination. So from this pharmacokinetic curve, we are able to gain relevant information. For example, we can see for how long the concentration of the drug is within the therapeutic window to have its action. But we can also see at what time the maximum concentration in the blood is reached, which is the T max. So from this curve, we are also able to calculate the corresponding pharmacokinetic parameters. An example is the AUC, which is also called the area under the curve, which represents the total exposure of a drug, in this case over 24 hours. Or we can calculate the drug half-life, for example, the T half, which indicates the time for the drug concentration to decrease with 50%. So now you know what we look into during pharmacokinetic studies. I would like to tell why it is important for pharmacokinetic studies to be performed. So PK studies, in short, are performed to gain insight in the absorption, the distribution, the metabolism, and excretion of a drug, as explained. And by means of pharmacokinetic studies, the appropriate dose of a certain drug can be determined for specific patient populations, for example, for children. But with these studies, we can also predict pharmacokinetic interaction or predict the effect of food, for example, on the pharmacokinetics of the specific drug. So I already gave children as an example of a specific patient population where we want to find the right dose of a drug. But when we perform these pharmacokinetic studies in children, there are some special considerations needed. For starters, it is important to consider the growth and the development of children. Children are not just small adults, and babies are not just immature children. So when a dose for a child is determined, this cannot just simply be done by correcting for the weight of the child only. Children grow rapidly, and there are a lot of developmental changes in a short period of time. And all of these influence the pharmacokinetics of a drug. For example, as you can see in the figure here in the upper left, the expression of metabolic enzymes change throughout growth, which means that the metabolism and therefore the exposure to a drug differs over time during development of a child. Besides differences that are caused by growth and development, there are also other factors that can influence the pharmacokinetics of a drug. For example, when a child is malnourished. The pathophysiological profile of a malnourished child can influence the pharmacokinetics, but also the response to a drug or the level of toxicity. This can be caused by delayed or decreased absorption, for example, or reduced protein binding, changes in volume of distribution, or reduced elimination of the drug. And in these specific cases, therapeutic drug monitoring could be helpful. By measuring the concentration of a drug, it can be checked whether the concentration of a drug is adequate or maybe toxic. Another consideration when we perform pharmacokinetic studies in children is the restriction in blood draw volumes. You can imagine that the blood volume in children is less compared to adults. So we cannot just simply take the same amount of blood as we take from adults. And as stated here, ensuring the safety and efficacy when performing blood draws on children, while also accounting for their emotional and physical well-being, is very important. As you can see here, there are certain guidelines on the allowable blood draw limits for children. And there are also differences for healthy and sick children, because you can imagine that a sick child is even more vulnerable and cannot lose too much blood, because this would be dangerous. Then another consideration in pediatric PK studies is that you are working with not just the child, but a whole family. Therefore, it is important to understand the family dynamic to think about the healthcare of the family, but it is also important to build a trust relation with the parents or the carers. Next to that, it is also important that the study drugs is administered in a correct way so that the child receives the complete dose. And to ensure this, tools such as pamphlets could be used and adherence counseling could be performed by nurses, for example, to check whether the child takes the drug every day as they should. And in this picture, you can see that the child, for example, is so young that the drugs need to be administered by using a syringe. And if drugs need to be administered this way, it is important that the parents or the carers are also instructed in the right way so that they can also do it at home like this. So now we've talked about the pharmacokinetics and considerations regarding pharmacokinetic studies in children. We would like to show you a video on PK studies in children. Of course, it is also important for the participants of a study, for the children, to understand what is going to happen when they come to the clinic for pharmacokinetic research. And together with Penta Foundation and a youth trial board, a video was made on what happens during such a PK day. So we're going to show that right now. And after that, I would like to give the word to my colleague, Angela Kolbers, who is going to tell you a bit more about the pharmacokinetic trials and the practical aspects of this. So I will stop sharing now.
Are you going to start the video or do I have to start it?
I will start sharing the video. Can you see the video?
No.
Not yet? Oh.
Yeah.
I see that Zoom is logging off, I believe. So I might be kicked out again.
Okay. Shall I take over? Then I've got the video on my screen.
I think that's a good idea. So I will stop sharing it.
Yeah. Yeah. Okay. Let me see which one I'm going to share. And then share sound, yes. And then go to the video, but it has to be bigger, I think. Where is it? Let me see this.
Yeah, we can see the video now.
Okay.
When you take your medicine, it spreads out into your body and it does its job. But only for a while. Then it leaves your body. So for your medicine to work, you have to take the right amount for someone your size regularly. This is called pharmacokinetics, or PK for short. Scientists want to make sure that the amount of medicine that people are taking is enough. But to find this out, they need help from people like you. A PK visit takes 1 full day at clinic. The staff are here to look after you and to answer any questions you have. They'll take a few tests and check you are well. Then they'll put a little plug in your arm. So with just one needle. The team can easily take a bit of blood a few times during your visit. When you've been given your medicine, you'll be taken to your room. And for most of the day, you can rest. Have something to eat and read. might even go home and sleep in your own bed. Exactly 24 hours after your first test, the team will take your last test. And after they check you are okay, your PK day is over. Your black tests are sent to scientists who look at how much medicine was in your body at different times. Your tests are compared with other people's tests. And this information helps doctors to give exactly the right medicine to people all around the world. Let your doctor know if you'd like to help by taking a part in a PK day.
Let me see how I get back. I hope you enjoyed that video. And as you can see here, I think I am unmuted, am I?
Yeah, we can hear you.
Yeah, okay, good. I can't see my mute button. You on the right-hand side, you can see we've got the video in English, in Lugandan and Izulu at the moment. I think the Shona version is being developed, and also a Dutch version we are developing. And as you can, you will understand, we developed this video to explain, to help doctors explaining pharmacokinetics and participating in a pharmacokinetic trial to children and also to their parents, because I think it's a very insightful video. Anne, can you confirm that you can see my slide now in full screen?
Yeah, we can see your
Okay.
slides.
So I'll continue not really where Anne left off, but I'm going to tell you a bit more about the setting up of a pharmacokinetic trial and which patients to recruit for these trials, how you make that choice, PK sampling, intensive versus sparse sampling, bioanalysis, which is important, that informs some information, your study protocol as well, and some which PK parameters we generate and the interpretation. Setting up a trial, you have to consider a pharmacokinetic trial. You have to consider whether you really want to standardize very much, or whether you want to mimic the real world situation more, and also what is possible. For example, when you perform a bioequivalence study in which we test whether the area under the curve and Cmax, so the exposure of a drug, of a generic drug, is similar to the exposure of the first drug that was registered. So for example, if a new company wants to make a new paracetamol, they have to do a bioequivalence study, and these parameters have to match very well. And that's when you really want to standardize as much as possible, because the only effect you really want to see should be the difference between the two pills with the same content, so the same drug, but a different manufacturer, for example. So that's when you really want to standardize, have a small population, healthy volunteers between a certain age, for example. But we also do studies, for example, in children with HIV, and studies in pregnancy, where we use opportunistic designs, which means that, for example, in pregnancy, women are already using the medication, and we only collect PK samples. So that's less standardized, but that mimics the real world situation better than a standardized, very standardized setup. So what do you have to consider when you're talking about which population to choose? Whether are you going to choose patients or healthy volunteers for your study? And which in and exclusion criteria are you going to put in your protocol? And for example, in the case of comparison of two treatments or two situations like food or non-food, do you want to have to want to compare an intra-subject control, are you going to have a control group within one person, or are you going to compare two different subjects, for example? And are you going to have a pharmacokinetic curve at steady state, or are you going to administer only a single dose? For example, when we do healthy volunteer studies, we often only administer a single dose, because also that then we are not exposing them to drugs if we don't need to. But when you have got an intra-subject comparison, you have to think about the washout period when you give a single dose. And also think of how are you going to administer the drug, with or without food? Will it be on a fasting situation, or are you going to give it with food? And usually we take over what is mentioned in the patient leaflet, so in the label of the drug. You also have to think about the food intake during the rest of the day and other restrictions, because I think from Anne's talk, it also was clear that food may influence absorption during over time as well. And you have to think about your sample schedule and sample volume, especially when we're talking about children. So PK sampling, how are we getting to this perfect or very desirable PK sampling schedule? For example, this is an example when we give an oral drug. There is a rule of thumb how many samples at what time points you should take to get the perfect curve. So that is, you would like to have 3 sampling points prior to Cmax or Tmax, 3 sampling points between Cmax and T-half, and then you have to continue when we are talking about the single dose conditions until 3 times your half-life. Or when we're talking about steady state conditions, you'll stop just before the next dose. And then it's important to have that sample just before the next dose. So for example, when it's a drug you give once a day, it will be 24 hours after the medication intake, as you also heard in the little video. And you also have to make sure that you can use at least 3 sampling points to determine the half-life. That means that you have to have 3 sampling points at the end of your pharmacokinetic curve. So for each individual, we'll collect the whole concentration time curve over this dosing interval, if it's at steady state, or until 3 times the half-life when you're giving the drug as a single dose. Is that important? Well, this is an example I made up myself, actually, where we can see that it really can influence, your sample schedule can really influence the pharmacokinetic parameters you get out of your study. So when we look at this schedule 1, that is a perfect schedule, having 3 sampling points before the Cmax, then having 3 after 1 half-life, and then go on. And when we look at schedule 2, we've got less points in the absorption phase, and also less points at in the end of the curve. But when we look at schedule 3, you also already see that something goes wrong here. We are missing the real Cmax. So here you see that we've got even less sampling points, and it will be very difficult to see the real excretion points at the end. So when we look at the pharmacokinetic parameters that are generated by using these schedules, you see that the Cmax in schedule 3 is not assessed accurately. Tmax almost, but the half-life also differs very much from what it really should be when you look at schedule 1 and schedule 2. So I think I hope I've made clear that choosing your sample schedule, especially for the for intensive curves is very important for the results you get out of your study. If you're missing your Tmax, if you don't have a sample taken at around the Tmax, you'll just miss it. And as Anne already said, for children, we are not always able to get that many samples. So in that case, we really have to choose our samples very cleverly to really try to get the Cmax and also the half-life and accurately assess the AUC. I'm also going to talk a little bit about sparse sampling because probably all of you have heard about. We've got intensive sampling, so we collect a lot of blood samples from one person on one day, for example, when we give an oral dose. But another thing we can do is collect sparse samples, so only one sample or two samples from one person. And collect the samples from a whole lot of different persons, and then try to generate the same sort of pharmacokinetic curve as you see on the right-hand side. So all these dots are different persons' blood samples, and from all these dots we'll generate a pharmacokinetic curve by a lot of equations. So that's also another way to get your pharmacokinetic parameters. And when are you going to collect these sparse samples? That also depends on what the aim of your study is. If you really want to know what is the lowest concentration all the subjects have just before the next dose, you'll have to sample mostly just before the next dose. But if you also want to know the real form of the curve, so to see the absorption phase and to be able to assess the entire exposure, you also will have to get a lot of samples in that first phase of the curve. So it also depends a little bit of what your question is. And it's not only taking the blood samples, but there's also something else that is important. The bioanalysis method, which means the method to analyze the blood concentrations or the plasma concentrations or the urine concentrations. So your laboratory has to be able to measure these concentrations, and they have to be accurate, because the results of the clinical trials can be used to make critical decisions supporting the safety and efficacy of a drug. And for example, also to it's important for safety of the children exposed to the drug in the future, to make sure that the exposure is really safe and efficient. We really have to be sure that what our lab gave back to us was the real concentration. And we sometimes run into problems, not really with the analysis method, well also, but for example, tenofovir alafenamide, which Anna told you about, is not really stable in biological samples. And we found that out during the setup of this bioanalysis method, and that also influences how quick after collection of the samples you have to centrifuge the samples and make sure that they are in the freezer very quickly. And in this case, we even just before we analyze the samples, we have to add an acid to inhibit the hydrolysis of TAF. So it's important before you start your trial to get some information from your laboratory, because they have done their validation tests in a certain sort of plasma. So you have to know whether they have validated the method in EDTA plasma or in heparin plasma, which will influence which sort of tube you will have to collect. And also how you have to store your samples, protected from light in the fridge or at room temperature, the maximum time between blood sample collection and centrifugation, for example. That's all information you can get from your lab, and the storage temperature and we need to have the storage temperature of the blood, but also of the plasma after you centrifuge it, and also the long-term stability. How long can we still analyze the samples after collection? And now I'm going into a few pitfalls in PK studies. What can happen which influences the pharmacokinetic curves? Now, for example, when we tell the people that we want to have a curve under fasting conditions, and somebody did eat just before dosing, that could influence the absorption of a drug. Also, treatment adherence, of course, when we're in the multiple dose setting. We really need the last dose before the PK curve is being taken to be really 24 hours in case of once daily dosing before the next dose, because when it's 12 hours before, when the child or the person took it in the evening and the curve is being taken, starts in the morning, will not start at the 24 hours after dosing, right? Sometimes the time of intake and scheduled sampling times are difficult to get. And sometimes we also see that the second dose of a drug was given too early. So when we are collecting a pharmacokinetic curve, Anne is asking something. Oh, maybe not.
Oh, sorry, didn't mean to.
The second, sometimes we see that the second dose of a drug was given too early, halfway a curve. I will show you an example. Or presence of interacting medication, which influences the concentrations of a drug as well. And sometimes samples can be swapped. So after centrifugation, the 1 hour and half an hour after dosing samples can be swapped. Don't do that in your curve. Well, I'm going to give you a few examples of how it looks like, what we as a PK analyst see when something goes wrong. So this is, for example, this is the normal curve. So we've got the time post-dose on the x-axis and the concentration on the y-axis, and this is how it should look like, just to remind you. And you see here on the left-hand side still how it should look like, and here you see, oh my God, something went wrong here at the 24-hour sample, because that's not what we expected. So I don't think we can be very interactive. Otherwise, I would have asked people what you think happened. But one of the scenarios we think about is that the person went home after this 6-hour sample, and then in the morning was instructed by the trial staff not to take their medicine before coming to the unit, but they were so adherent to their medicine that they just took it, and because they do it every morning at breakfast. So that's what we sometimes see. And then we have to find out from the sites whether that was really the case and whether we can exclude that sample from the analysis. And what has happened here, you can see that this curve, we are missing a few samples here. And I think we have missed a few samples. Maybe there was not enough blood that could be taken, or the cannula was clogged or something. But here you can see that can influence the curve as well. As I told you, that now we are just missing the Cmax. And now we don't have enough samples left over to capture the whole curve. And this is really, here you can see that there's only a tiny bit of medication in the blood, and that could be because of maybe vomiting or diarrhea on the day of pharmacokinetic sampling, because we can see it starts at the right level, but then it doesn't go up anymore. So usually you get information on instructions on what to do when a child vomits on the PK day just after dosing. And here is something, well, it's a little bit strange to see a curve like this. So maybe here samples have been swapped one way that can happen at several time points during the process of the sample, right? It could also happen in the lab when they analyze it, that they put the tubes in the LCMS in the wrong order, for example. And that's really difficult to find out whether that really happens. So this is difficult what to do with it. And then there's also, you have to also think about interacting medication. Is it forbidden during the entire protocol, or can you give instructions how to prevent the interaction to be really present at the moment you give you take the pharmacokinetic curve? For example, dolutegravir, a drug most of you know, I think, is influenced. The absorption can be influenced by calcium due to complexation. But we know that when we take it, both the calcium and the dolutegravir, not separately, you can overcome that interaction. So that's something you always have to find out before you do the study. And I think we're well in time, and we still have 5 minutes for questions as well. So I will
Thank you so much,
sharing.
Wait a minute, Angela.
I will stop sharing my screen now. Is that okay?
Yes, it's fine. So we can have the Q&A session from the participants. Please feel free to raise some questions after the presentation, or you can even type in the chat, and the presenters will ably respond to you.
Maybe we can put the links to the videos in the chat. I don't know how to do that. I can try to do that. I've got a question for the attendees. Do you like the videos? Do you think it's useful in practice, because everybody can use them now? Would you show it to a child that would potentially participate in your study? Or everybody is asleep?
Angela, are you sharing?
Oh, yeah, I don't see the questions coming. I will try to put the video thingy in the. Yeah.
So Angela, you have a question here.
There we go. Okay. Good.
In the chat.
Oh.
Or Anne. They beg your pardon on the PK explanation on the PK graphs. Or can you share?
Oh, I can't see. Is there a question in the chat?
Yes.
I can't see it.
Please navigate to the QA section. That's where the question is. Q&A section.
Okay.
So Anne, have you seen the question? It's from Jamila Namwanga. She said thank you, and then she begs your pardon on the explanation of the PK graphs.
So were they not clear, or can you add, Jamila?
Jamila, can you clarify your question, please?
Hello, Jamila, you unmute now. You can clarify the question.
Are there specific graphs that you want Angela to provide more explanation? Because she shared several graphs. Okay, so Anna shared the link.
Yeah, I just sent a link to the YouTube video, and there you can also see the other languages.
Okay.
And people can always send us Anna and me emails if you've got a question. I will put my email address here in the chat as well.
Yeah, I also will do that.
Okay.
But maybe the presentations were very clear, so then.
Yeah, so people can always contact us or ask us about the slides.
So Anna is sharing her email in case members have questions or additional questions to. Okay, so we'll straight away go and have the polls. So take time and answer the question and respond to the poll. We'll appreciate to have your feedback. Maybe we can give it some minutes. So far, 17 people have responded. I encourage members to respond so that we get some feedback. Thank you. Thank you for those who have responded to the poll. There are about 5 questions. So thank you so much for responding to our poll. So in just a minute, I'm going to end our poll, and then I'll adjourn this meeting. Thank you so much. Thank you so much for taking part. So feel free to share. Okay. Thank you so much for taking part. Wishing you a good evening or good morning to all of you. Thank you.
Thank you.
Thank you.
Okay, thank you. Goodbye.
Ciao. Thank you all for